Okay, so first, thank you, Troy, for the invitation. And thank you, everybody. Thank you, my friends from US, my little friends from Mexico and all Latin America, Colombia, Peru, and my dear friends from Portugal and Brazil. And today, we are going to make a seminar, but in fact, we have two seminars. And next month, we are going to make another one with about retraction mechanics in class 2 malocclusion, but in adults patient and bad growers patients. Today, we are going to talk about good growers patients, and I'm gonna focus my efforts in SSW mechanics, SSW way of retraction anterior teeth, okay? So I'm going straight to the point because I would like to say lots of things to you. And let me start here. So the development of straight-wire appliance, everybody knows that was a significant advancement toward finishing orthodontic treatment. However, the straight-wire arch-wire slots in blue can cause some difficulties early in the treatment, like an anterior overbite and lateral open bite in premolar and molar area, like you can see here. Okay, so in about 1987 or 89, Dr. Peter Kessling, to overcome this problem, got a bracket, an edgewise bracket, and cut those opposite parts and achieved this design that you can see in your right side here. And he made the same now, but with a straight wire bracket, cut the same parts and achieved this design. This is tippet bracket, okay? So tippet brackets is nothing but a straight wire bracket that produce or permits a distal movement very easy. Even if you are using a full-size arch wire, if you are working with tippet brackets on canine, the canine can be moved distally very easy way. This way you are seeing. And the arch wire will not deflect. So it works very well and facilitate a lot the anterior teeth retraction. So let's take a look at this example. We have here a canine, an uprighted canine with a straight wire slot and on its brackets. And if we pass through its slot, even a thinner arch wire, a night arch wire, when we insert this arch wire, the opposite parts of this arch wire on incisors and the molar, the canine will be moved forward and its roots move distally till to achieve the ideal position that we are expecting to the end of the treatment. But we are in the beginning of the treatment and we expect to correct the class 2 malocclusion. And this is the first problem that appeared at the very beginning of straight wire technique, conventional technique. The class 2 malocclusion become worse. In addition, when we insert this arch wire, this part of arch wire, the anterior and posterior part, the molar and the incisors is gonna be moved down and the premolars and molar is gonna move up. And will appear here a lateral open bite and anterior overbite, okay? So I got the same typodont and I made the following change. I have changed just the canine brackets. Look at closer. I put tippet brackets on canine and you can see the arch wire passing through its slot without any deflection, without any problem. And in addition, if you are in the beginning of treatment with overbite malocclusion with overjet, if you want to correct the overbite since the very beginning, we can make a curve in the arch wire, okay? A kind of speed curve in the arch wire. But when we try to insert this curve in the conventional straight wire bracket, it's almost impossible, especially if this arch wire is a very hard arch wire, okay? So this way, it's impossible. We are going to have always the undesirable effects. If we change this bracket and we put here tip-head brackets, we can pass an arch wire with a curve, and we can achieve the cervical part or even the deepest part of the vestibule, and we can make, since the very beginning, we can start open the bite. We can, because of the canine brackets, we can open the bite, we can move distally the anterior teeth, we can move the canine distally. It means what? We are going the opposite way, just changing the canine brackets, okay? So take a look at this case. It is the first day, the very first day, and we are retracting teeth, promoting alignment and leveling, and open the bite. Everything at the same time, okay? I wrote a paper with a friend of mine, Weber Urs. It was in 1998, about utilization of tip-head canine brackets to facilitate the vertical control of anterior teeth and the straight wire mechanics. It was written in Dental Press magazine, a magazine from Brazil. Okay, so let's talk about SSW mechanics. After this introduction about tip-head brackets, I've lost 5 minutes maximum, because tip-head brackets is a bracket that we use in our mechanic on canines only. And after talking about SSW technique, I'm talk a little about working with self-ligating brackets in SSW technique. We call it SSW SL. It means self-ligating simplified straight wire. But I'm going to talk about this later, okay? So let's come back to the conventional one. We have some characteristics and some features, most important features I put here about SSW. First one is a special bracket prescription, because if you are thinking about making or working or experimenting our technique, we have to start with this prescription of brackets. We work with low friction, with light forces, tooth movement control, because if you are thinking about work with very low friction and freedom and anterior teeth, we have to pay attention in tooth movement control and tooth control, because it's very easy to lose control when you are working without friction, especially if you are a self-ligating practitioner, okay? And of course, torque at the end of the treatment. So the special bracket prescription, as we talked before, we use straight wire brackets on incisors and premolars and bicuspids. And incisors we use, and all brackets are narrow, because we think narrow brackets we have more facility to insert arch wires on it. We have less attrite between the arch wire and the slot. And on canine, just on canine, we use tip-head brackets, okay? So here, you can see in your left side, the brackets, the incisors brackets, and the right side, the canine bracket. All brackets have the same slot, O22 by O28, okay? And the canine stipial bracket. And I think this is the sine qua non condition to make this technique. It is to use the O16 original wire as a kind of Australian arch wire, okay? The O16 original wire is a very thin arch wire. Think about O16 arch wire. It's very thin, but the ordinary one is very soft. And this one is very thin and very hard, very strong, okay? So we have a strong arch wire with lots of freedom inside the slot. This is sine qua non condition for me. So we work in the very beginning, when we are making traction, we work with O16 arch wire, and from the middle to the end, we use O20. From the middle to the rectangular one, okay? O20. There are more than one original wire on TP. There is Bowflex wire, Premier Plus. For us, Premier Plus is the best, okay? This is, you can work with Bowflex wire or original arch wire. It's up to you. But for us, Premier Plus is brighter, is stronger. I love this arch wire. I can't live without this arch wire, okay? So, talking about low friction, on the incisors, because of this space that there is inside the slot, we can slide the anterior teeth, even making a little tip, a little distal movement, okay? On the other hand, the canine, we have more slide, more freedom to move, because tipial brackets slot open when the canine is tipped, open from O22 to O28. And we can even move more than that, okay? It's an overtip. If you need an overtip of canine crown, you can achieve. Okay, why narrow brackets? Because the distance between them is small, is almost the double when you use twin brackets, you know? This way, this arch wire is easier to insert. We have less active inside the slot because of this. Why a different bracket just on canines? Because canines are not anterior teeth and not posterior teeth. Canines are in the corner of the arch. The corner of the arch, it is the place that we have more force concentration. And in addition, the anterior teeth, the incisors, we don't want to move the incisors distally, because if we move the upper incisors distally, we will have diastema, a space between them. In the anterior incisors, we want to promote just retraction, not distal movement, but the canine, no. Canine, we want to move it distally, okay? Different than the anterior teeth. Because of this, I prefer work with straight wire brackets on incisors. So, take a look at this canine. Upper canine, we have 11 degrees of tip, and the lower one is 5 degrees. So it's the first problem that appeared in the very beginning, because the upper one is gonna move immediately more than the lower one, okay? And a class 2 malocclusion is gonna be worse. So when we insert this arch wire in the molar tube, in the upper and lower, the arch wire deflect. and the, the arch wire will deflect, and the premolar is gonna move up along with the arch wire, and the incisor is gonna move down. And the lower arch occur the opposite. The lower, the premolar is gonna move down, intrude, and the incisor extrude. Sorry again. So we will have this effect, you know? Okay, but you can say, no, I don't have a problem in having this problem. I can wear some short elastics here and wait for the arch wire achieve a flattened way, a flattened position. Okay, you can wait, and let's compare before and after. You have here a worse class 2 relationship, but for me in that time, I got very upset because how long does it take from the end of the start and to the end of the alignment and leveling? I remember when I was straight wire practitioner, it took about 1 year at least. We put a sequence of night arch wire, 012, 014, 016, 022 to achieve 21 by 25 or something like that, okay? So, and after achieving, if you are a very smooth guy and you are not worried about finishing very fast, you can wait this time. But after waiting this, you have to start the retraction phases. And when you start pushing the canine, all the undesirable effects appeared again, okay? So, if you are thinking about working with tibial brackets on canine, we have to think about that canine move its ground first, and after we have to upright its crown, and we use a sidewinder spring. We are going to talk about this later, okay? The sidewinder spring. So we have to make this idea first crown, after root, okay? This way. So now I think is the most important slide of the webinar is how to promote retraction with this arch wire and these braces, these brackets, okay? So first, we are going to get a Premier Plus arch wire, 016, make 2 circles on it, and an anchorage band in the posterior part. It's a band that we make between the molar and premolars area, okay? And we are going to wear a 2.5 ounces class 2 elastics, must be 2.5 ounces. It means about 73 or 75 grams of force. This is very important. And in addition, I think this is most important thing, is our tube. I got this tube from Tibia Technique. We use a double tube, a rectangular one that is near the ideal position, in the cervical position, around to 036. But think about that. We are going to work with a 016 arch wire in a 036. We have lots of freedom in the posterior part. We can slide very easily in a very easy way, okay? So another important thing, there is a relationship between the forces that we use, the anchorage band force and class 2 elastic force. It means that if we make the anchorage band, we make this band in the posterior part, the arch wire must be resting in the deepest part of the vestibule, not forcing, but and not before. Okay, that must be resting in the deepest part of the vestibule. When we insert the class 2 elastics, we have to look at the arch wire position. If the arch wire is in that position, it means that the elastic is too light. But if you insert the class 2 elastics and the arch wire moves down below the incisors brackets, is too strong. So the ideal is here in that position. I wrote for you, fix this. The ideal relationship force between elastics and arch wire is when the arch wire gets the same level of the incisor slot. This is the ideal. So you can try before giving for the patient the elastics, you have to make the anchorage band, put the elastics and try it and look at the level that the arch wire is gonna be, okay? That is very important. And the class 2 elastics is always 2.5 ounces of force. So let's see a vector of those forces. When we move the arch wire from the deepest part of the vestibule to the incisors arch wire, incisor slots, we have here a vertical vector of force. And class 2 elastics promotes another vertical vector of force. So if we calculate the resultant, we have to have a resultant passing through the CR point. That's the ideal resultant to promote good retractions without any undesirable effects and the loss of torque. Okay, and you can see the movement is going to be along along with the long axis, okay, through the long axis of the teeth. Okay, but we can have not a class 2, but a severe first division class 2, where the incisors are very protrude in a horizontal position. So we don't want a very strong anchorage band. We would like to have a stronger elastics to promote this movement of the incisor. So in this case, we are going to make a lighter anchorage band, because this way the anchorage band vector is going to be shorter and we will have a more horizontal resultant. In this way, the incisor is going to be moved and controlled their torque. Okay, so very strong class 2, first class 2 malocclusion, lighter anchorage band. The opposite situation, when we have a very strong, severe second division class 2 malocclusion. So here we want intrusion much more than retrusion. Okay, here in this situation, we want lighter class 2 elastics. In fact, we want a stronger anchorage band, but we will not make stronger any, just the rest in the deepest part of the vestibule. So if you want the vertical vector be stronger, you have to become the horizontal one lighter. It means a lighter class 2 elastics. So here, with a lighter class 2 elastics, we have a shorter horizontal vector, and our resultant is going to be more vertical, and we will have much more intrusion than retrusion, and we will solve this problem very easy way. okay? What about canine? When we should upright canines or verticalize its root? So we have to wait to the end of the retraction. We have to give the canines freedom. So don't put any side winder springs on canine before finishing the retraction. When the incisors border is touching each other, this time is the time to insert the sidewinder springs on canine and change the class 2 elastics. The test, we're gonna use a short class 2 elastics. So here you can see the sidewinder springs working, okay? Can you see the leg of sidewinder springs? When the lower leg moves up, the up leg moves on the left. This way, the canine's roots is gonna move distally, and we will have here canine's roots uprighting. Okay. I made a movie and I put in my Instagram. And if you want to see this again, you can see in my Instagram. Here you can see inserting the sidewinder springs. The best way of inserting is from occlusal to cervical position. There is a vertical slot in all brackets from SSW prescription. You insert in the vertical slot. And to activate the sidewinder, you just move with your plier. It's very easy. Anyway, if you want to see more, I have on my Instagram another clinical cases, tips. Go there and see. Okay. So we have just finished after talking about torque control. After the straight wire technique, straight wire brackets, we thought finally we have brackets that will give us a way of promoting easy torque. We don't need to make torque with our hands. That's not so easy this way, because when we insert the arch wire here, first let me talk about the canine. If the canine is uprighted, or the canine is in a distal position, we have to put on it tip-head brackets, okay? If the canine is already in a very good way, good position, tipped with a slot in a horizontal position, we don't need to change the canine brackets. We can work with conventional straight wire, okay? So in this example, is in a distal position, I put tip-head brackets. So we think that when we insert the arch wire on incisors, arch wire slot, to produce torque, we have to see the posterior part, and the posterior part must be above the molar tube, okay? And when we move this posterior part down, the anterior part is gonna move this way. The root's gonna move this way. So it's very easy, isn't it? This way. It happened? No. It's not true. Because when we move the posterior part of the arch wire down, we are going to move all the arch wire. The incisor is gonna move along with it. Okay, and we will have a deep bite here, and the spaces between more incisors. I think everybody had this experience before when you would, now I'm going to insert rectangular arch wire to achieve torques, and suddenly the bite is moved down. There are some spaces in between the incisors. Okay. To avoid this, I thought I'm going to make curve, a speed curve, okay? So when we make this speed curve, the incisor is going to move up. So this way, we don't have this undesirable effect of deep bite. Perfect. Let's see what happened when we make a speed curve. The incisors don't move down, but move forward, okay? And the diastema is appeared at the same way. So let's concluding. How is the SSWA of producing torque? We make a speed curve in the arch wire to avoid incisors overbite, okay? And we wear short class 2 elastics at the same time. What does short class 2 elastics mean? From the circle, from the hook to the first premolar. With a 316 medium elastics, it produces about 50 grams only, okay? And these elastics avoid forward incisors movement. Perfect. So this way, the incisor is not going to be moving forward, even downward. And we can wait for the torque without any problem. And here you can see the results. Okay, I think it's all. We talk about special brakes, low friction, tooth movement control. Now it's time to see a clinical case. This is a girl with a good profile. I think it's 11 years old girl. Short face, lip seal. For me, translating this is good grower patient, okay? Especially because of short face. This one is not a good grower patient. She has a convex face. There is no lip seal. The chin is very poor. Take a look at the girl on the left side. The goniacal angle is very beautiful. You can see this angle. Anyway, the girl in the left and the right side, we are going to see her next month in the next webinar, okay? And the bad grower patients. So I think this, I think this kind of patient, I think good growers, it doesn't matter if you are working with a conventional treatment or elastic class 2, whatever, all treatment is gonna be good. It's gonna be finished well. The patient good is the best thing we have to achieve. Okay, so the girl exhibit a class 2 malocclusion, both sides. Here is almost a one-step malocclusion with about 7 millimeters of overjet, and doesn't have any problem to achieve lip seal. The profile, we go straight to the lower facial high, and the good growers, ours is always patients with lower facial high. In class 2 malocclusion talk, not class 3. Pay attention. So I used to say this to my patient, my students. If you want to see a good patient to be treated in a class 2, take a look at his lower facial high. Is it decreased? So the guy is good, okay? And the girl has these characteristics, and we have to move the mandible forward and down. There is one more thing I would like to show you. It's short smile arch. What does smile arch means? It is the distance between the upper lip, the stomion, the upper lip, to the stomion, the lower lip. The distance is very short. This case is very dangerous if you intrude the upper incisor a lot. the girl can lose the upper incisor exposure and become with a old face, okay? So because of this, we started our treatment making anchorage band in both arch wires, especially in the lower arch to intrude the lower incisors. This arch wire is the Australian, I think, is Bowflex wire, 016. And here we have finished when we bonded and put the upper arch wire and lower arch wire, okay? And the lower one, we have 2 arch wires. But take a look at here, we have class 2 elastics and bumper R sleeve. Bumper sleeves is nothing but a piece of rubber that is between the molar and the canine and to maintain the bicuspid space, okay? And at the same time, the bumper sleeves will transmit the class 2 elastics force from the canine to the molar. So because of this, you have to pay attention when you insert the bumper sleeve, must be very tight between the molar and the canine. Need to be very tight for transmitting the force. This way, the molar is going to be moved backwards along with the incisors. Always the incisor is making retraction, the molar is going to be moved along with, okay? So, when we finish, when we finish the retraction, you can see in the slide, the lower slide, we change the 016 arch wire to 020 arch wire, and we start wearing short class 2 elastics. Why? Because when we finish the retraction, we want to promote torque, become the anterior teeth torques better, you know, but it's impossible. We change from 016, a very thin arch wire, straight to a rectangular arch wire. So we have to pass to 020, just between this phase, between retraction and torque, we use 020 along with short class 2 elastics. Take a look at the short class 1, is from the circle to the first premolar. And here we already have 025 by 021 by 025 arch wire. And if we take a look at closer here, you can see the sidewinder springs are working. Take a look at them. Is inserted by occlusal to cervical. When you insert the sidewinder springs from occlusal to cervical, the legs is gonna be looking at the mesial face always, okay? Another thing we have to repair here, that the premolar, the bicuspids are without braces. There is no brackets on bicuspids because the bicuspid is they're not in a very good position, and it's very difficult to bond premolars because their buccal face is very convex. So you can see and look at the premolar, it's a physiologic assentment. So I did not bond anything. The second molar as well, but I'm not used, do not bond second molar. I used 9.9% of my cases, I used to bond second molar, especially the lower one, okay? But in this case, I got very impressed because it was very fast. Less than 1 year, I was thinking about removing very fast the braces. So we took the brace off, and it did not bond second molars. The girl got very happy because it was very fast treatment. Of course, the girl was a very, very good cooperator, okay? She wore class 2 elastic a lot. So we can see here before and after. And now, I would like to talk something about making the same technique, the same way of treating, but using self-ligating brackets, okay? Okay, I'm straight to the retraction phase. Let me ask you something. Why the SSW prescription of brackets is light as well as self-ligating brackets? Because self-ligating give us lots of freedom, but SSW, we have less than freedom, but works very well. That's my question. Because of tibial brackets on K9, I think it's important in the anterior teeth, but I'm sure if we use self-ligating brackets, it's even more, we will have even more freedom, okay? For me, the great difference, the SSW prescription, is the molar tube. This round tube, I mean the 036 tube, is a huge tube. So we have a clearance inside the arch wire. And this clearance is very important indeed. Take a look at here in the left side. If you have an arch wire here, if you want to move this arch wire, you have to have lots of freedom in the molar region. Take a look at here. Okay, the molar, the arch wire is moving because we have lots of freedom in the posterior part. We have a huge clearance in the posterior part of the arch wire. So when I realize that, and I start working with the huge tube in posterior part, and with self-ligating brackets in the anterior part, the technique became perfect, okay? One more thing is when we make this movement with encouragement, for example, the incisors move up, okay? And when we use class 2 elastics, the incisors move down and distally. So, but we want to move down, and we will not want the incisors would move forward. So for me, this movement here, I will translate from torque control. When you have much more facility of obtaining this, it means torque control. So if we have both vectors, we are distalizing, yet at the same time we have torque control. This way, the incisors, we're gonna move along with, through their long axis. This is the main idea, okay? So when we have a 016 arch wire inside the slot, we have some freedom, some clearance here. But when we insert the ligature is gonna push this arch wire, and this arch wire will touch in the deepest part of the slot, and we'll have artery there, okay? So, take a look at this experience once more. I just touch in the root. Here you can see we have a 016 arch wire with the SSW brackets prescription, the incisors, and a rubber ligature. But we have freedom, lots of freedom, because if you see here, given just one touch, the gravity force will move this teeth, okay, this tooth. But let's take a look at now with a self-ligating bracket. Take a look at the difference. No way. So much freedom, okay? Much more freedom than the other situation. So it means what? This movement is gonna be much more increased because of this freedom. It means what? That we will have much more control, torque control, if we use self-ligating brackets and O16 arch wire with an anchorage band in the posterior part, and the O36 tube. Okay. Let's take a look at this typodont. This is a typodont that I made in my office, and I inserted inside the hot water just once. It took about 20 minutes without removing it from the water. And you can see that all the malocclusion solved by itself. Just input this pair of arch wires, and let's see again. Oh, take a look at the anterior teeth. On the anterior teeth, we have two arch wires. The O16 arch wire, Premier Plus, pathing in those teeth that we can insert the O16 in a very easy way. The other teeth, I mean lateral, that we cannot insert the O16 on it. We insert night arch wire, O12, O14. But if you look at closer in the lower arch, we have the O16 arch wire inserted in the second molar in the incisors, the lower incisor only. And all teeth in the lower arch, we insert just a night arch wire. And you can see that those teeth is going straight to the O16. Okay, and we can see here the anterior teeth movement backwards and upwards now. The movement and canine relationship became class 1. And let's take a look, let's take a look at the posterior teeth. Take a look at the premolars and the molar. The premolar are achieving a good relationship without making anything. This, in fact, is a problem for me because in my courses, with typodont course, we used to insert twice in the water. It's done. Practically, it's done. So let's see this in a girl. It's an 11 years old patient. She came to us claiming to solve the overjet. I think it's about 10 millimeters at least of overjet. And we have the right side, one step class 2. The right side one step, this left side, almost one step class 2 as well. Okay, here we can see the overjet better. And the profile, patient's profile, in fact, this patient is not a good grower like the other girl that we saw. But it's not so bad. Here we are seeing the upper incisor exposure and the smile. If you look at closer the smile, we can see that there is a buccal corridor here. Now, there's a black space, black corridor here. So this arch, this upper arch, is asking for expansion, okay? So many people would make an inspection with a Haas appliance expansion, but we are going to see her palatal at the end of treatment. Okay, so here I told you that the best patient to be treated, it is those one that the lower facial height is decreased. That one is one by one. Okay, one by one. So it's not so good, but I look at her chin, and her chin was beautiful. She had a very beautiful chin. And I was afraid about the making retraction because the girl had a very strong overjet, but there was no very strong overbite. I couldn't intrude. So when you reduce the overjet, you show much more the gummy, the gingiva. I told her, but I thought for my daughter, I would try just 3 or 4 months, and I would say if we remove or not. Okay, so here you can see the very first day we are using 016 Premier Plus arch wire, and it's almost like the typodont. Okay, we have 2 arch wires, 1 arch wire promoting alignment and leveling, the other arch wire, the steel arch wire, the Premier Plus, is promoting the retraction. We have anchorage band in the posterior part, bumper sleeve, transmitting the force from the front to the back. Okay, and here we can see more clearly that first we make the 016 Premier Plus arch wire. The anchorage band, the arch wire is going to be here. When we move from there to here, we see what teeth is going to be easy to insert the 016. In this case, it was on canines and incisors and lateral incisors. We put just a piece of night eye arch wire, insert this piece of night eye arch wire inside the bumper sleeve, just a little piece inside the bumper sleeve. Okay. And here we are. Another thing, look at the brackets. There is a red point in the incisors, the green and the lateral. It means that I have just finished to bond. It was a student of mine. This case was made by students in our course in Piracicaba here in Brazil. And she was a dad, a mom and daughter. And they took about all morning long making bonding and making the arch wires and put the elastics. So here, take a look at here. This is very important. Take a look at the canine root. The canine root is almost in the ideal position. It means what? It means that the slot is in a horizontal position. On the other side, the same. The slot is in a horizontal position. So if we have not this position, but a little bit more inclined, tip it, take a look at the arch wire position. Let's move a little bit more. No way. Here we had to change the canine bracket and put tipped brackets on canines, okay? I've made lots of clinical cases this way. I work with self-ligating brackets on the incisors and tipped brackets on canine. And after finishing the retraction, I've changed it because in out, at the end of treatment, I've changed it and then I put the original one, the self-ligate original one again, because of the in out, okay? So here, 1 month later, just 1 month later, this girl was a very good cooperator as well. Let's take a look at closer. The very first day, we start working at promoting alignment, leveling, correction overjet, and overbite. 30 days after, we had this situation. Let's take a look at the lateral. The lateral moved in 016 archwire direction. And the incisors, we are promoting alignment and leveling, and the incisor is gonna be moving backwards, not forward. Let's take a look at the canine relationship. Here on the right side, we have almost, they are touching each other. Just 30 days. And here, 30 days more, and the overjet was shorter. Here, we already had a touch, the incisor, the retraction was finished because the upper incisor and lower incisor was touching each other. And we still have in the lower arch some crowding. If you look at the tooth 42, we have here some night-eye arch wire on it. So here, in this situation, we have to move, we have to change the long class 2 elastics to short class 2 elastics. And the upper arch, we have to change from 016 to 020 because we are thinking about inserting a rectangular arch wire, especially with self-ligating brackets. It's impossible to stop working with 016 and go straight to a rectangular arch wire. We must insert a larger one, around the larger one. So we use 020, okay? This way we will put the canine in class 1 relationship, and we will prepare to achieve more torques on the upper incisors. I think we need torque, but if you think about the huge movement that the incisors have made, we are in a good control, torque control, I think. So we've changed now 020 Premier Plus on the upper, the lower 016 all teeth because we've bonded premolars, the lower one. And the next step is the 017 by 025 TMA arch wire. When we are working with self-ligating, we cannot insert straight a steel 019 by 025 arch wire. It's impossible. The windows, the braces window, it's impossible to close them. Okay, so I like a lot this 017 TMA by 25 because with TMA, frontispiece timoleon arch wire, TMA, we are able to make some bends on it, and at the same time, it's not so hard like steel arch wires, okay? We can make some deflection in the anterior teeth. We can close the windows, the braces windows, okay? So here, the results 2 months later with still wearing or using 17 by 25. In the lower, a 14 by 25. We insert now here. And take a look at the relationship. This slide is better to see the torque working. On the left side, when we have just start touching the incisors, the canine wasn't in a class 1 relationship. Take a look at from the middle to the right, take a look at the canine relationship and premolar relationship. How important is a torque, a good torque to achieve good finishing at the end of treatment. Okay. I have some dates here. You can see clearly from the left to the middle, 1 month, 2 months from February to April, May, June, July. Okay, you can see that we corrected the class 2 malocclusion, or the retraction in 6 months. It means that the SSW prescription, conventional, if we compared with self-ligating prescription for me is the best. Okay. So here we can see the overjet compression. The other side, the correction of the overjet lateral, 6 months from January to July, and from the number, the month 6 to the month 7, you can see the huge difference here. It is everything about because of torque. Okay, now we have to finish. But if you look at closer, the molar is not in a good position. Why? Because we didn't have in that time the second molar. The second molar wasn't inside the mouth, the girl. So the molar was working. It's a kind of war, you know. You are the posterior teeth against the anterior teeth. And the molar was losing this war. Okay, and we still have any problem in the front here. If you, here's the X is not so good, it's too long. But the X, the canine X and the canine, the incisor X. But I'm talking about the incisors border are touching in the lower braces, you know? It means that we have to improve the anchorage band, but the molar, we cannot improve the anchorage band, but we have to solve this problem that is touching here. So in that case, we put a bite ramp to maintain the bite, the anterior bite. At the same time, I put the bite ramp just a little bit disocclude in the posterior part. This way, we can promote the intercuspidation, the molar intercuspidation in a better way, okay? This bottom here, you can see the bite ramp permit us to remove the anchorage band. And at the same time, we are using or wearing short elastics to promote the molar's intercuspidation. The buccal face and lingual face at the same time. Okay, I love this slide. For me, it's the best because in the very beginning, we look at the left side, we think about promote some expansion, but class 2 elastics along with bumper sleeve promotes the molar rotation. Think about with the move, push with like class 2 elastic here, the bumper sleeve will transmit this force to the molar. And the molar should be looking at to the canine according rickets, both cuspids. I mean, the distal buccal cusp, if we drawn a hep, the buccal distal cusp to the mesial, should be looking at the canine. Okay, but we make this movement with the molar is gonna move because the molar tube is here. When we move the molar this way, the tube is gonna be moved along with it, and the bumper sleeve is gonna be moved along with it as well. Okay, this way. And the bumper sleeve start working like a lip bumper now. It's transmitting force and working like a lip bumper, okay? This way, the tongue is gonna move up and promote the expansion of the arch wire. So here, a 19 by 25 arch wire. I have never inserted 21 by 25 still in these prescriptions because it's a MBT prescription, and we have, for me, it's the best prescription for treating class 2 because we have 17 degrees in the upper incisors. So it's easier to achieve 12 degrees, for example, for the incisors. You don't need to insert a full-size rectangular arch wire. On the other hand, when you wear lots of class 2 elastics, the lower incisors tends to move forward, and we have a -6 millimeter of torque in the lower incisor. You promote a torque, a resistant torque on the lower incisor. This prescription is perfect for this technique, okay? So, the dad's girl moved from Brazil to USA, and the girl was crazy about going to visit him. And she asked me, she made this, please take off my braces. So we removed the braces and put in her mouth some aligners. We use in Brazil aesthetic aligners and some attachments in the molars. And when the girl came back from USA, she came back with this occlusion. Let's take a look at the lateral, for example, the lower lateral, the number 42. The canine is in a better position, the lateral is in a better position. We opened the bite a little bit more. I think the aligners worked well, okay? So, here, just comparing. A huge overjet. We've made it in 1 year and 2 months, this correction. Here, the faces before and after. We have very good lip seal. The gummy smile was because of the retraction. We couldn't intrude the teeth, but there is no more black corridor here, and the profile, lateral profile. I make black and white here and puts one side by side. Now I'm going to correct the nose position and move it to the end, and we can see the chin and the lower lip movement, okay? So, what about those patients? Convex profile, long face, lip seal, gap. There's a gap. They are bad growers. So, I think it's all for now. In June 25, we are going to talk about bad growers, moving molars mesially without undesirable effects. Okay, so I pass the word to Troy and for any question, okay?
Thank you, Doctor. Wonderful presentation. If you could leave your presentation up, I think some of the questions refer back to specific cases.
Okay.
So if you wouldn't mind being able to go back to those for reference. Recently, real quick question that came in about 10 minutes ago. Dr. Shaw asked, why do you not put brackets on the upper 4s and 5s on that particular case?
Why I did not put brackets where?
On the upper 4s and 5s. I believe that was during the self-ligating case. The bicuspid? Yes.
Because we did not need, okay? Because the teeth moved by itself along with the movement. This one, problem is talking about this.
Mm-hmm. Yes, sir.
Okay? Move along without any problem. So, but I could bond the premolars, but we had to make a curve, a speak curve to maintain the premolars intercuspitated. But some cases, it's not happening in all cases. I think 7-8% of the cases, I have to bond the upper premolars.
Okay. And then how do you generally correct class 2? Do you just use elastics? Dr. Amzar was asking that.
In good grower patients, yes, because I've already worked with extraoral forces, functional appliance, and I've realized that all good grower patients, the results is almost the same. Herbust appliance, the patients that are not good cooperators, we used to put a vector appliance, okay? But for me, it doesn't matter. Works well, in good growers works well, but I use elastic because for me it's easier, and I think for the patients it's easier as well, okay? But in bad growers, not. Bad growers, we have sometimes to make extractions to promote the lower facial height decreasement here, and some adults, I use IZC screws. Anyway, but we are going to talk about this in the last month. Any more question?
Yes, when the curve of Spey is so deep on the mandible, how do you fit in an 016 stainless steel wire?
Can you repeat, please? When the curve is P in the lower arch?
Yes. How do you fit in an 016 stainless steel wire?
It's very difficult. First, with 016 arch wire, I don't have any difficulties, okay? I can insert and fix it. But after that, I have at the finishing of the treatment, I have to flat the speed curve. So we have to put a sequence of arch wire, and I use flexible arch wires, Unitau, TMA arch wire to achieve a flatten of the speed curve.
Do you put an anchorage bend both in upper and lower arch wire? And when do you stop doing the anchor bend?
Good question. I use anchorage bend because this beginning of the treatment is I've learned from TPI technique. And TPI technique, they use to make anchorage bend in both arches. But in the upper arch, we have an anchorage bend here, but we have at the same time a class 2 elastics. Okay, but in the lower arch, there is no class 2 elastics. So there is only one vector of force, and this vector of force will move the incisor forward. So it's a rule in my office. In the lower arch, I always bond lower premolars, because the premolars will still the force that is directed to the incisors. This way, we will not have this movement of the incisor. Concluding, I use always anchorage bend in the upper arch. When we have a extrusion, we have to intrude the incisor, for sure. And the lower arch, the anchorage bend is lighter, much more lighter, and we bond premolar aiming to avoid the lower incisors protrusion.
Would you ever consider starting a case with a Unitau wire?
Sometimes I started, the question is if I ever, both arch wires, Can you repeat, please?
Yes. Would you ever consider starting the case with a Unitau wire?
Just Unitau without the 016 Premier Plus?
Yes.
Yes, sometimes our time is very tight, and we don't have enough time to do all things, bond the braces, and making 016 arch wire, Unitau arch wire, teach the patient how to insert the elastics. So I use a Unitau first. In the second month, I immediately put both arch wires.
Do you ever use reverse Unitau wires? And if so, in what case?
Yes, I use reverse Unitau arch wires in the very strong overbite. And first, I have to look at the upper incisor exposure. Some adults that came to my office with a very poor upper incisor exposure, and they have very huge, very strong overbite. So I have to aim my effort in intruding the lower incisors. In those cases, I use the revert speed curve.
In the self-ligating case again, Dr. Rodrigues, did you open the bite by placing composite on the occlusal of the lower first molars?
Sorry, repeat please.
Sure. In the self-ligating case, did you open the bite by placing composite on the occlusal of the lower first molars?
Sometimes. I don't like posterior composite. I don't like posterior composite, but sometimes we have to put, because think about, the literature says that the anterior composite is for brachycephalic. Posterior composite is for dolichocephalic. But if the guy is dolichocephalic, it's supposed to have an open bite here. Okay? It's dolichocephalic. But if the guy is dolichocephalic and we have an overbite, probably he has a gummy smile. And when you put composite in the posterior part, you are increase the gummy smile. So when I made this, I made it just for 1 month to the other months. The other months, I try to put anchorage band or make something different that, okay?
Going back to the short elastics part of the presentation, what is the advantage of switching to the short elastics to lower bicuspids versus just maintaining class 2 elastics to lower molar?
Because the long class 2 elastics will keep moving the anterior teeth backwards. The short class 2 elastic is with a curve in a cervical region here, will just maintaining the incisors. The incisor will keep stopped here, not moving. Long class 2 elastic, all time long, you don't think about that. This is a tipiad technique. Tipiad technique, you solve the overjet, keep wearing long class 2 elastics till achieve edge to edge. Because the anterior teeth, upper anterior teeth will keep moving. But I don't want to move anymore the anterior teeth. I just promote torque. So if we wear short class 2 elastics with a curve naturally, because short class 2 elastics can promote an overbite, with a curve in the upper arch, we can keep the incisors touched without moving any teeth.
Okay, thank you. If the canine brackets are tied to the loops on the arch wire, a diastema can't open. So why do you need to change the brackets on the incisors to straight wire?
You have to repeat again, please.
Sure. Now, this was earlier on in the presentation. If the canine brackets are tied to the loops on the arch wire, a diastema can't open. So why do you need to change the brackets on the incisors to straight wire?
Okay. If I have to change because you are talking about the end of the retraction. If you tied the canine on the circle, you are right. There is no B diastema here. Okay, but when you are promoting retraction with the tip-head brackets, the incisors tends to move distally, and I don't want to move the incisor distally. If I move the canine distally, will appear a diastema here. If I move the lateral distally, the same. The central, the same. So if you move every single anterior teeth distally, you will make this problem and will appear here. The anterior teeth must be moved, just making retraction. The arch wire must be long at the end of the arch wire without making any distal movement. At the end of the retraction, he is right. You don't need to change any brackets. But in the very beginning, if you compare, but when I change it from straight wire brackets on incisors and I start working with elastics, I've realized that the anterior teeth move faster as tip-head brackets on incisors, but with much more control.
Dr. Rothstein continues there. It appears that the lower premolar brackets have been switched right to left. She says, won't this, together with sidewinders and class 2 elastics, cause a lot of proclination in the lower incisors?
Changing this way? Change the premolars swift, okay?
Mm-hmm.
This is a good idea. But we have, because this way we have more control in the anterior teeth. But I didn't need make any change it when we wear straight wire brackets on the lower arch. I didn't get the idea.
Thank you. In the first case, Dr. Rodrigues, to what do you attribute the class 2 correction? Mandibular growth, forward dentoalveolar movement in lower arch, or retraction of upper dentition?
In my mind, all class 2 solution is dental alveolar movement. If you get the papers, even wearing papers that was made with Herbst or Vetor, whatever, at the end, when the patient become adult, you can see that there is no, just a little bit, almost is always dental alveolar movement. I don't believe in mandible growth. Yes, I believe, but if we compare, it's about 0.7 millimeter each 2 years, okay? So, and not so at the end of 2 years, 2.1 millimeters, but not 2.1 millimeters forward, is forward and down. And the difference in the face is almost nothing. I can believe. It's my way of seeing this, okay?
Dr. Fine asks, do you upright the lower canine in class 3 cases?
If I upright canine in class 3 cases, yes, I upright it. First, I move it, and when I working with self-ligating prescription, an MBT prescription, I have -6. So when we are working with 016 Premier Plus, there is no difference how much torque there is because we are with a round arch wire inside the slot. But after finishing the retraction, I'd like to promote the torque. So this way we change the position of the braces. I put I cannot say, how can I say this in English? When you move this way, okay? And the torque is gonna be the opposite. It's gonna be +6, not -6. When you keep the anterior teeth with a short class 3 elastics, while the anterior teeth would move inside the symphysis. Of course, we have today we have TMJ, we have X-ray, goods X-ray, that you can see how large or how thin is the symphysis, if it's possible to move inside that or not, okay?
In the second case, Dr. Rodrigues, can you explain why you placed blue buildups on the lower molars?
Second case, explain here. What did I made?
Why you placed blue buildups on the lower molars?
Okay, okay. Because we have a problem, and this is probably was touching. Let me see. In the tube, because the cuspid, the upper molar cuspid was touching in the tube, okay, here. And we made this composite and works well. I like this, but not so long using this. As soon as I can remove, I remove it, okay, because of long face.
Just a couple more questions, Dr. Rodrigues, if you're okay on time. Would you cinch back the arch wire in the lower arch to prevent incisor proclination?
If I switch back?
Cinch back the arch wire in lower arch to prevent incisor proclination.
What does cinch back means?
Put a bend in it.
The lower arch.
Yeah, how you're going to prevent lower incisors proclination.
Using, as soon as possible, a rectangular arch wire. In this case, for example, you can see the lower, can you see my computer?
Yes.
The lower incisors is tipped lingually, okay? So because of this, we put here a bumper sleeve in the lower arch. But when the incisors was almost in a good position, let's see, we move the bumper sleeve in the lower arch and maintaining the bumper sleeve in the upper arch. Okay, when I see the the lower incisors is near the ideal position, I remove the bumper sleeve. But when the lower incisor is too protrude, I think in a different way of treating, perhaps extraction or sliding, or when is very near the ideal position or a little bit beyond the ideal position, I used to put braces in the lower arch first, promote the alignment and leveling. And when we arrive in a rectangular arch wire with torque control, in that phase, we start working with class 2 elastics.
Going back to the second case, Is it okay to place anchor bends and open the bite with blue stops on the molars at the same time in deep bite cases?
It was the first time that I made this. I put, let me see, the second month is here, the second month. Probably almost there is no more. There is no more composite here. 1 month later, can you see? Just in the first month was touching, and we didn't make bends. We boned the tube. So we were afraid about losing the lower tube. So from the first month to the second one is practically without. But there is no problem because it means about 1 millimeter, 2 millimeters at maximum. But I like to put composite in the posterior part. But as soon as I can remove, I remove it.
Okay, I think we're good. Is there anything else you would like to offer, Dr. Rodrigues, in closing?
Sorry?
Is there anything else you would like to add before we close?
No, for me, is everything okay? I would like to thank one more time for everybody to join us. I hope we can pass something productive for you, and I would like to about my English. You know, in Brazil, you speak Portuguese all time long. Suddenly, I had to start talking English. It was very difficult to me, but I think the pictures took by itself, and we could make some changes, okay? Once more, thank you very much for everybody, and thank you very much, TP and Troy, for the invitation.
Wonderful. Thank you, Dr. Rodrigues. And thank you, everyone, for joining us this afternoon for this webinar. Check your emails. You will be receiving a link to the CE quiz and evaluation. Upon successful completion of those, your CE certificates will be emailed to you. If you have any questions, you can direct them to Dr. Rodrigues or myself, troy.smith@tportho.com. Thank you all, and we'll hope to see you back in June for part 2 of Dr. Messias Rodrigues' Simplified Straight-Wire Technique lecture. Thank you, everybody. Have a great day.
Thank you a lot.
All right, bye-bye.